Gallaher from Moffitt Cancer Centre in the States, and she's going to talk about, let me get my adaptive therapy in basal cell carcinoma. Thank you very much, Jim.
Thank you. Thanks for organizing and for all the great discussions so far. All right, so when I think about personalization or making a twin, I think that it has to center around the data, right, that we can collect. And I guess since I've put my focus a lot into metastatic disease, we're lucky if we get this kind of multi-scale data because it's usually hidden, it's distributed, it's hard to measure. So, what I've kind of thought about with putting all this data together is we often get maybe single time points of spatial data, maybe really resolve spatial data, but then as you move into more frequent sampling, then you start to lose resolution. So how do you put all this together? And with this trial, when this came along, it seems like a really cool set of data in that we're going to get spatial data over time. So basal cell carcinoma, super common. You usually just cut it out most of the time. You catch it early. So this is occurring on the basal cells, and that kind of separates the epidermis from the dermis. And there's no real definition for advanced basal cell carcinoma, only that it's hard to resect. So at some point, it's better to give systemic treatment. But this treatment is super toxic. And so there's been plenty of studies that have tried intermittent therapy, and this works pretty well for multiple lesions, but maybe not advanced disease. So this trial was set up to compare arms, one with a continuous treatment, one with an intermittent treatment. We are leading this sensitive resistant PK model that's adaptive on arm C, and this is sponsored by Genentech, Roche, and they're doing their own kind of adaptive that's more PK based. And so these will eventually accrue 6, 6, 11, and 11 patients on each of those arms. So the first thing that we figured out that we needed to do is to, they've often measured these lesions just as the long axis, but we realized that if you look at this lesion, it's not all the same. There's kind of a wound, and this is literally the wound that won't heal. It's visible on your skin, but we know that it's kind of this competition between normal tissue and a lesion. So we set up this pipeline to kind of pull out and normalize all of the brightness of these lesions, and then define this color metric that's basically based on the physiology of wound healing. So looking at the different colors that are existing in these lesions, and this is a subset of them, there's different colors that are associated with, say, ulceration when it's kind of dipping down deep into the skin, when it's healed over, when there's scabs, they all have different colors. And this isn't, necessarily going to capture all of that, but it does better than the long axis. So what we did is kind of train, we pulled out these regions and classified them to have certain characteristics here and identified them. So you can see what this random forest classifier is doing for the rest of the lesion based on these windows, and then gave them weights. And then that gives us kind of a weighted area that determines a burden. You can see there's also one for tattoos. So the first patient we had tons of tattoos, which seemed to be a burden at first, but now we can see that it's actually kind of a map to identify when they don't put the ruler on there, so we could scale it. So this first patient here had 7 lesions. And what we see, they're all different. And then they respond differently, but we can see that the long axis over time, you can see where the purple is where the drug is on, and the white is when it's off. That the long axis may not change much, but this color metric is kind of changing over time. And that's what we're using really to make decisions, to make recommendations. Ultimately, the clinician makes the decision. And then, we have to translate that back to the long axis for the clinic to actually use. We also see there's different response dynamics, and this is a patient with 2 lesions. You can see there's delays, so we had to eventually incorporate these pharmacodynamics. We also had to come up with kind of this strategy for dealing with multiple lesions that may not act the same. So what we did is ultimately identify upper and lower bounds for every single lesion, and anytime one of the lesions would dip below the lower bound, we'd take the treatment off, and if it went above the upper bound, it'd go back on. That was our strategy, and still is, for dealing with all these multiple lesions. And so this is coupled with this mathematical model. It's just got a sensitive and resistant component, and these two, the drug ultimately binds up with this AAG, and in that form it's not usable, but then it slowly comes out of it and is usable. So this kind of helps with those delays, and we can kind of constrain, by fitting to this data, constrain these parameters and see whether there's maybe more sensitive and resistant, and use that to help whether we would recommend a treatment to be on or off if we're kind of nearing into that resistant release. So we still have a lot of work to do. We're still accruing patients. You can kind of see the swimmer's plot there of the different arms and how these patients have been, their schedule has been on here. And what we didn't know before is that they may have their tumor shrink and then they go off trial to do another treatment. So it's hard to compare these outcomes when our strategy is for long-term control. So we're still kind of dealing with outcomes comparison. But what we really didn't, I think we thought about, but we're thinking about more, is what we see is on the surface. And so what we're trying to look at is what's deep below that we can't see. So we've paired this also with the agent-based model to see what other factors are contributing and whether we could determine how to make better decisions based on what we see above and what might be below. And then we're doing more spatial analysis. So I've talked to a few people here about, how to characterize the neighborhood of these tumors a little bit better, and there's still a lot to do. And so these are the people that have been involved. Sandy leading it, and Masood helps with the trials. Zenab is the clinician that leads that, and Ken is a dermatological pathologist that has been helping with that color metric.
Thank you very much.